My name is Anne Mwirigi, and I'm a consultant hematologist at the Aga Khan Hospital. I would like to thank the organizers of AORTIC 2021 for inviting me to share the results of our abstract on outcomes following COVID-19 infection in patients with hematological malignancies at our hospital. It is now known that patients with hematological malignancies have increased odds of COVID-19 infection, and this is for all-time diagnosis as well as recent diagnosis. The strongest effect for recent diagnosis is in acute leukemias, essential thrombocythemia, and multiple myeloma. The worst outcomes have been recorded in patients who are recently diagnosed, older patients, and those with progressive disease. We conducted a retrospective analysis of all the patients at our hematology oncology unit with hematological malignancies who also got COVID-19 infection from July 2020 to May 2021. We recorded the type of hematological malignancy, the treatment received, their remission status, and the time from the diagnosis of the hematological malignancy to COVID-19 infection. We also recorded the severity of COVID-19 infection, the treatment received, and the patient outcome. Out of 2,400 patients with both hematological malignancies and solid tumors who were seen at our hemato-oncology department in the named period, there were 24 patients with hematological malignancies who got COVID-19 infection. As you can see from this pie chart, majority of these patients had CLL, multiple myeloma, or AML, with 5 patients each. There were 4 patients with myeloproliferative neoplasms and COVID-19 infection, 2 with diffuse large B-cell lymphoma, and 1 each for Hodgkin disease, CML, and large granular lymphocyte disease. 17 out of the 24 patients were admitted, and they were treated according to Aga Khan Hospital COVID-19 protocols. Majority required oxygen and dexamethasone. 5 out of the 17 admitted also required tocilizumab. There were 9 deaths in these patients. 3 of these were in patients with CLL, 4 with AML, 2 with diffuse large B-cell lymphoma, and 1 with multiple myeloma. One of the patients with AML was actually seen at an alternative facility where she had been receiving a stem cell transplant for acute myeloid leukemia, from which she recovered well, but unfortunately succumbed to COVID-19 infection. We had a relatively high mortality rate, which is comparable to reports from much larger cohorts, with 37% of our patients dying, which was 59% of all inpatients. Of the 9 patients who died, 4 died because of severe COVID. 1 patient died with moderate COVID, which was complicated by a myocardial infarction. This patient had no risk factors for an MI, and hence this was a complication of COVID thrombosis. 4 of the patients died due to their underlying hematological malignancy, with 3 of these being a newly diagnosed AML, and 2 of these having newly diagnosed AML and asymptomatic COVID. We found a higher than 50% mortality in patients who had aggressive disease or a recent diagnosis. As I've already mentioned, 4 of the deaths were in AML, 2 of whom were newly diagnosed and had asymptomatic COVID, 1 of whom had developed myeloid sarcoma, which was aggressive, and the 4th post-bone marrow transplant contracting COVID. Of the 2 patients with diffuse large B-cell lymphoma, the first was newly diagnosed and also had uncontrolled HIV. The second had progressive disease, which was refractory to treatment, and uncontrolled HIV. Interestingly, in contrast to the data that showed that the older age was a risk factor for poor outcome in COVID-19, we found that only 4 out of 10 patients over the age of 70 had died despite having COVID-19. However, a closer look at those patients indicates that 2 out of the 3 deaths in CLL were in this older age group. However, they had stable disease requiring no treatment. Therefore, we concluded that our cohort was too small to draw conclusions about the outcome related to the age in this cohort. Thank you.